Alrighty, folks. It's that time, and welcome to the Medical Exercise Specialist Study Group. This is a makeup or a reschedule session for session number 4 last week. We had some technical difficulties with our webinar software. We use a program called Webinar Jam, and it actually interfaces with Google Hangouts. Well, Google, in their infinite wisdom, made some changes with their Google Hangouts, which meant the interface between Webinar Jam and Google Hangouts just didn't work. So we had some problems last time. So hopefully we fixed those problems. I think we have. We already had one webinar this evening. For those of you that are actually doing both, the Spring 2016 study group as well as the Fall 2016 study group, you know that earlier this evening, we went through session number 12 for our MES study group for the spring of 2016. So that study group is ended. We now have just the one study group, and this evening we're going to make up for session number 4. We didn't do it last week, so we're making up for it this week. Now, I know we've got some changes that are going on because you're watching this via Google Live. You can't submit questions, and I know that the developers of our Webinar Jam program are working on that. So please, I'm going to ask you to be patient with us. If you have any questions, email those to me at medicalexercisespecialist@gmail.com, or you can email them directly to me at drmike@postrehab.com. So please accept my apologies. This isn't something of our doing. It's just a matter of Google Hangouts made a change, and when Google makes a change, everybody has to deal with it. So my apologies. So if you're listening in out there and you're watching, thank you for joining us. Again, I appreciate your patience and your tolerance for allowing us to have the technical difficulties last week. But we're back here today to try to make up for it. We will meet again next Tuesday. Now, next Tuesday is election day. And a bigger issue, next Tuesday is my birthday. I'll be the big 5'5". I'll be 55 years old. Now, I'll be in Washington, D.C. because we've got a course this weekend in New York City. So I'm looking forward to meeting a lot of you in New York City. And then from New York, I'm going on to Washington. So next Tuesday, please remember to cast your votes. If you're here in the United States, make sure you vote. But also, after you cast that vote, make sure you think it's Dr. Mike's birthday. So anyway, that's what we got going on right now. Okay. So again, this is our MES study group. This is session number 4 for our MES study group. And I know you were tolerant with us last week, and I appreciate that. So thank you for showing up with us today. Now, we're going to get a good recording of this. We'll post this guy out to the website as quickly as we can if you can't make it. And we'll get back on track next week. And next week, we'll talk about the hip. So we'll be back on track next week. Then we'll take a week off after that, and we'll motor through the rest of the year. And I think we'll do really well. So again, thank you for your patience. Thank you for your support. And we're just glad to have you with us. All righty. So this evening, we're going to talk about session number 4. We'll talk about actually the spine this evening. We'll talk a little bit about the cervical and also the lumbar spines. And again, because we don't have access with our room where you can actually submit questions, I'm going to ask you to email me at either drmike@postrehab.com or medicalexercisespecialist@gmail.com. All right, so let me just quickly check my email here just to see if we've got anything that's come in yet. I don't think we have, but let me check. As you can see, we're broadcasting from here at Medical Fitness Pros. You can see part of our facility here. And also, don't forget, folks, we're having our MES, I'm sorry, not our MES, our MedX Pro Summit here in December 2nd through 4th. If you're a MedX Pro Network member, the summit is free for you. And if you're interested in becoming a network member, go over to medxpronetwork.com to get more information. We're actually going to do an advanced our summit this year is going to be our Advanced Medical Exercise Specialist Skills Workshop. So we're going to do a lot of hands-on here with the assessments, the functional assessments, the standardized joint assessments, exercise. So it's actually kind of that missing component after the MES on-site course or the online course. It's that missing component where we actually talk about the MEST skills. So we're going to go over that. That'll be December 2nd through 4th here at Medical Fitness Pros in Houston. All right. So without further ado, we're going to move on, and we're going to actually get to our lesson here. As I said, this evening we're talking about the spine. We got quite a number of slides that we're going to go over here. We've already got our slide presentation out. Let me just check to make sure it's up to speed and ready to go. Looks like it is. And we're going to go through our time tunnel. Now, again, folks, if you're listening in out there and you have a question, you can email the question to me at drmike@postrehab.com or medicalexercisespecialist@gmail.com. So we're going to go ahead and switch over and do our screen share. So there we go with our screen share, and you should see my slide presentation here in just a second. Again, if you have any questions, email me at drmike@postrehab.com or medicalexercisespecialist@gmail.com. So we're going to go ahead and get started here. Alrighty, everyone. Good evening and welcome to the Medical Exercise Specialist Study Group. This is session number 4. In this session, we'll talk about clinical anatomy, pathology, and medical exercise training guidelines for the spine. This lesson encompasses MEST lessons 17 through 21. So please remember to review lessons 17 through 21. Make sure you submit the quizzes before our next meeting. And remember, this is actually a makeup session. So you got to submit these in a week. And I know you've had a little bit of time on these. So you'll have to submit these next week because we're actually having our study group again next week. Because remember, this is a makeup session. So let's go through these slides here real quick. Now you can see here, this is a slide showing you the lumbar spine. We've got a view here to the left, which is a lateral view. Then we have our view to the right, which is a posterior view. Now notice with these lumbar spine vertebrae, they're large blocky structures. They've got disc in between. The opening in between each one is called the intervertebral foramen. And then when we look at the diagram here to the right, you can see we have these short, stubby spinous processes. Now remember, the long spinous processes are found in the thoracic spine. The short, stubby ones are in the lumbar spine. And remember, these lumbar vertebrae are designed for weight bearing. So they're short, they're stocky, and you'll notice the transverse processes are also very short, very thick. So both the spinous and the transverse processes are rather thick in the lumbar spine. You'll also notice here with this diagram, we have some soft tissue structures shown. You can see the anterior longitudinal ligament. That this runs along the entire anterior aspect of the lumbar vertebrae here. Actually, I should say lumbar vertebrae, the entire spine. It goes all the way up into the cervical region. You'll also notice along the posterior aspect, we have these interspinous ligaments. We also have the supraspinous ligaments. So these ligament structures actually are running the length of the spine, both anteriorly with the anterior longitudinal ligament, and then posteriorly with these spinous ligaments, the interspinous ligaments. They're running the length of the spine. You'll also notice here we have the intervertebral foramen, and exiting through those intervertebral foramen are some of the spinal nerve roots. Now, when we look at motion in the spine, it all boils down to what we call a spinal motion segment. It's simply the vertebrae above, the vertebrae below, the intervertebral disc in between, and all the posterior articulating structures. And articulation means they're actually touching each other. So this is a spinal motion segment. You see the vertebrae above, vertebrae below, the disc in between, and then those posterior elements that also articulate or touch. Now, basically, when we look at the spine is a series of teeter-totters, okay, or seesaws. You know, each individual spinal motion segment or each individual vertebrae is really part of 2 spinal motion segments. So spinal motion actually originates in these individual motion segments, and these motion segments are interconnected with each other throughout the entire spine. So if you see, if I have a problem at one motion segment, it's going to affect another motion segment at some point. Now, this spinal motion segments, or these 2 here, really depict what goes on in the lumbar spine. The diagram on the left actually shows you what happens with lumbar extension. So when we extend the spine, okay, what happens here is the disc itself, the nucleus of the disc, moves anteriorly, moves forward. The intervertebral foramen actually closes, as well as the facet joint will close. Now, when we bend forward, the diagram here to the right, what we see is complete opposite. The nucleus now moves posteriorly. The foramen opens and the facet joint opens too. So this relates back to this idea of the spinal motion segment. Now when we look at spinal motion, the diagram on the left here depicts extension in the spine. Diagram on the right depicts flexion in the spine. Now this diagram gives us a better view of the individual lumbar vertebrae. You can see on the left, we have a superior view of the lumbar vertebrae. You can see the vertebral body itself, nice and stocky and thick. You can see the intervertebral foramen, that's where the spinal cord is located, but you can also see the transverse spinous processes as well as that eventual spinous process. Okay, so you see the transverse processes here and the spine of the vertebrae, which would now be collectively the spinous processes. The diagram here to the right shows us the vertebral body again, but notice we have the superior articular process, and then we also have the inferior articular process. The superior articular process articulates with the inferior articular process of the vertebrae above. That articulation forms what we know as the facet joint. Facet, F-A-C-E-T, Facet was a French anatomist and physician who discovered these joints and obviously named them after himself. These facet joints are covered both the articular spinous process, or the articular process, I should say, and the superior articular process are both covered with hyaline cartilage. So when you see facet damage occurring, that facet damage will damage the cartilage, and eventually, if enough time and wear and tear and damage has occurred, guess what? We'll see arthritic changes, because wherever we see damage to articular cartilage, eventually we see arthritic changes. So this is a prime area to eventually see arthritic changes, is right here at these facet joints, the inferior articular process as well as the superior articular process, because they're both covered with hyaline cartilage. Here's another diagram showing the intervertebral disc. Now the disc is a shock absorber, but also the disc is very important with spinal motion. So this intervertebral disc sits in between these two vertebral bodies, and it actually gets nutrients from the vertebral body above as well as the vertebral body below, because these nutrients actually pass through what we call the intervertebral end plate. You can see here now we have a better view. You can see now you can see the vertebral segments themselves. You can see the disc, and you can now see these spinal nerves. Now, when that nerve coming off the spinal cord passes through, or actually exits through, that intervertebral foramen, is called a spinal nerve. When it's on the other side, it's actually more interior to the intervertebral foramen. It's actually called a spinal nerve root. So when it exits the intervertebral foramen, that's what it's called, a spinal nerve. You can also see the facet joint here is close articulation to the nerve root and also to the intervertebral foramen. Next, we see here a superior view of the a lumbar vertebrae. You can see the spinal canal here, or we would also know this as the vertebral canal. This is where the spinal cord would sit. Now, this is more of a cervical vertebrae, and the reason we can tell that is because it has a very long spinous process, and the vertebral body is rather small and rather sleek. But what this is showing you here, and it says lumbar spine, my apologies, but what we're really trying to depict here, folks, is the actual spinal cord and the meninges sitting in this intervertebral foramen. So you can see we have this epidural space, then we have the dura mater, okay? And that dura mater now actually covers or surrounds that spinal cord. Then we have the subarachnoid space, and then we have the pia mater. So this spinal cord, which is covered by the dura, the pia mater, as well as the subarachnoid space, is sitting in this epidural space. Okay, so you can see the spinal cord is actually protected and is suspended in this vertebral foramen. And then when we look at that vertebral foramen collectively together, when we look at all the vertebral foramen together, that now becomes the spinal canal. You'll notice here we have a vertebral vertebrae here, and you can see the vertebral processes here. You can see the transverse processes. You can see the spinous process. And please remember, these processes are actually places where muscle structures are actually attaching. And you can also see the superior articular process here. When that articulates with the inferior articular process, that's where we actually have a facet joint. You can also see the cortical rim of the vertebral body as well as the consalis space in the middle. That consalis space is actually more like a trabecular bone, whereas the outer portion is more like compact bone. You could also see the pedicle here, as well as that pedicle is continuous with the lamina. So from the point where you see the pedicle all the way up to the spinous process, that entire area there is known as the lamina. That becomes important in a few moments when we start talking about spinal surgeries. This diagram here again depicts what we looked at earlier: spinal flexion, now depicted on the left, spinal extension depicted on the right. You can see now when we go into extension, when we go into flexion, looking at the diagram on the left, my apologies. When we go into flexion, that disc moves posteriorly. The vertebral bodies now are moving anteriorly, but the facet joints are opening, okay? And that means the foramen are opening. Whereas we look at the diagram to the right here, we can see now with extension, those facet joints are now closing, okay? The nucleus is moving anteriorly, but also the vertebral foramen or intervertebral foramen are actually closing here. Now we look at the intervertebral disc here. This is important because this disc actually is vitally important. It actually kind of acts like a ball bearing. It's vitally important to motion in the spine, but also it's a shock absorber. Now, that intervertebral disc has two components. It has a nucleus, which is in the middle, a nucleus pulposus, and then it has the annulus around the outside, the annulus fibrosus. That annulus, depending upon which anatomist you read, may say anywhere from 13 to 20 rings. But the important thing is that the rings, each alternating ring, has its fibers running in an opposite orientation. So you may have one orientation where the fibers are running longitudinal, then the next orientation, fibers are running actually more vertical. So what we see here is actually each one of these layers now reinforces the strength of the disc itself. So that idea of herniating a disc with just simply one movement is almost insane. What we do see, though, with disc herniations is it takes multiple tears of the annulus over time to eventually cause a disc to herniate. Now, can we get a single movement that causes a disc herniation? Yes, but it's very rare. Most of the time we see disc herniations as a result of continual annular tears over time from motion. You'll also notice with this vertebral body here, you can see a cross-hatched area here. That cross-hatched area represents the intervertebral end plate. Now, the end plate is both on the superior vertebral body as well as the inferior vertebral body. So we have end plates here on both the top of the vertebrae and also on the inferior portion of the vertebrae, which means the disc above and below are being fed nutrients. Now, this end plate is made of fibrocartilage, which means it's not hyaline cartilage, which means nutrients can pass through it relatively easily or readily. So what happens here with the lumbar spine, the disc gets its nutrients from just simple movement. So the more you move around, the more nutrients your actual disc is getting, as long as the end plate is intact. But now here's the interesting thing. The end plate is the most often damaged structure in the spine. Very often damaged. So what we find now is with the end plate, this end plate, when it's damaged and it becomes arthritic, now the nutrients can't pass through and enter the disc. As a result of that, we now start to see the disc deteriorating. So this is where we start to see degenerative joint disease over time, now causing these discs to actually shrink over time, which in turn is a result of arthritic changes. Here are end plates, and you can see the end plates are both on the inferior aspect of the vertebral body above as well as the superior aspect of the vertebral body below. So the disc actually gets nutrients from two directions. We can see here now we have a cross section of the spine, and what we're looking at here are the ligament structures. We mentioned earlier that anterior longitudinal ligament that runs the length of the spine along the anterior aspect, but also you can now look inside and see we have a posterior longitudinal ligament running along the back side of the vertebral bodies, but you can also see we have a ligamentum flavum. Now that ligamentum flavum is important. We'll see it here in just a second. That ligamentum flavum runs inside the vertebral canal or the spinal canal. And when that ligamentum flavum is damaged, which is normally damaged with any type of spinal injury, it increases in size and thickness, which now means it starts to cause a narrowing of the vertebral foramen, which is where the spinal cord is housed. We see a lot of times when spinal surgeries are done, the surgeon will also go in and excise a significant portion of the ligamentum flavum, because once that ligamentum flavum becomes inflamed, it thickens, and that thickening now can compress the spinal cord. You can see here now a posterior view to the left here along the posterior aspect of the vertebral bodies, and you can see that posterior longitudinal ligament. Now on this view, you won't see the ligamentum flavum. You notice here to the right, we have a diagram showing you a posterior view of the sacroiliac area. You can see here the sacroiliac ligaments as well as the iliolumbar ligaments, which actually is two components. And at one point we think that iliolumbar ligament was actually a muscle. We think at some point in human development that was actually a muscle. This gives you an even better diagram now. Looking at the diagram here to the left, you can see the anterior longitudinal ligament. You can also see all the posterior ligaments along the posterior aspect of the vertebral bodies. You also will see here to the right very good diagrams showing you the network of ligaments around the sacroiliac joint as well as those iliolumbar ligaments. And you have to understand there's no muscle structure that crosses the SI joint. Muscle structures come up to the SI joint. The erector spinae, the quadratus lumborum, the piriformis, but none of these muscles actually cross the SI joint. So this SI joint pretty much is out there flapping in the breeze, except for these ligament structures. So now we mentioned this in the MEST program, that a lot of this piriformis syndrome stuff we're seeing is not piriformis syndrome. It's really indicative of having an SI joint problem. So you can see there's more muscle here crossing the SI joint, which means these SI joints are very susceptible to injury, especially with natural childbirthing, or blows directly to the SI joint, or blows directly to the leg along the at the bottom of the foot, or the plantar surface of the foot, that now can drive these SI joints out of place. Here are some of our muscle structures. You can see the erectors here. Okay, the erectors are running the length of the spine. You can see we have both a superficial layer, we also have a deeper layer, and then we have the deepest layer of the multifidi. And remember, these multifidi are vitally important because they provide intersegmental stability. They connect between individual lumbar vertebrae, and that's where we actually get the segmental stability between each vertebrae, which we call intersegmental stability. That's where spinal stability comes from. It doesn't come from the erectors, it comes from these multifidi. And we've talked about in the MEST program with some of the pathologies, we see these multifidi being compromised when we have clients that have had back surgeries, chronic pain, as well as clients that have had disc herniations. We see these multifidi undergoing some significant changes that make them less functional and less likely to provide stability. Here's our quadratus lumborum, and as I've said earlier in our lessons, this is actually the workhorse of the spine. You can see here the diagram to the right. You can see the quadratus lumborum attaches to that last rib, comes down and attaches to the iliac crest. There's a portion of that quadratus lumborum that attaches to each one of the lumbar transverse processes, and then there's a branch of the quadratus lumborum that originates on the transverse processes of these lumbar vertebrae, and it comes down and attaches to the iliac crest. So you can see this muscle has 3 layers, and this really is the workhorse of the spine. When you bend forward past, say, 70 degrees of flexion, your erectors aren't working. It's primarily your quadratus now that's going to bring you up from that position back into the upright position. All right. There's our quadratus again here, the diagram to the right. You can see the quadratus there, but you can also see the psoas. Now, here's an interesting thing to think about. How many of you have clients that you're doing exercises to stretch or release the psoas, and you continually stretch and release the psoas? Stop and think about this. Look at this complex. If I have a very weak quadratus lumborum, could that quadratus be so weak that the psoas is trying to take up the slack and become tighter? And as a result of taking up the slack, it now means that maybe this person is in slight flexion, but you keep releasing their psoas, but the psoas keeps coming back being tight every time you see them. Could the psoas possibly be tight because the quadratus is so weak? The psoas is trying to make up for the weakness of that quadratus. So please, if you would, make sure you check quadratus strength by doing a hip hike, but also before you release that psoas, stop and think, do I also need to work on strengthening the quadratus? Again, we have our deep muscle structures here. You can see here the top diagram is showing you those superficial layer, but you'll notice the deeper layer shows us the multifidi. Now, these multifidi are vitally important. They're intersegmental stabilizers. They start at the spinous process of one vertebrae, go down to the transverse process of the vertebrae below. Then they have a second head. They have both a long head and short head. They have a second head that's a long head that starts on the vertebrae and goes down 2 levels to the transverse processes. So what we see here is with these transverse processes, we've got these multifidi that are connecting 1 level below and then 2 levels below. So these muscles are really important as being intersegmental stabilizers of the spine, vitally important. And this is why spinal stabilization works so well. It targets these multifidi. Now, if you have a client who's had chronic pain greater, low back pain greater than 90 days, they've got a disc herniation, or they've had back surgery, you can pretty much bet the multifidi have been compromised, which means now you've got to engage the client or initiate a program of spinal stabilization. With that concept of spinal stabilization, an even more important concept is that of the lumbar protective mechanism. Now, this is a cross section through the trunk at the level of L3. You can see the L3 vertebrae here, and you can see also the abdominals. You can see the quadratus lumborum. You can also see the psoas, but you can also see the transverse abdominis, the external and internal oblique muscle structures, as well as the erectors. Now, all of these structures are designed to protect what structure here? The vertebrae. So regardless of the direction the forces come from, these muscles were designed to absorb that force by contracting, dissipating that force over the entire muscular corset of the trunk, and protecting that force from entering the vertebrae, where it could damage a disc or it can damage a facet joint or anything along the way. So you can see here, it's not so much important that idea of just strength, but it's the idea of strength and stability, and this idea of the lumbar protective mechanism coming in. Vitally important. Now we look at the nerves in the spine, and you can see here coming off the spinal cord, we have an immense number of nerve structures coming off. And when they actually directly exit the spinal cord, they're called nerve roots. Once they pass through that intervertebral frame, and that's when they become the spinal nerve itself. So you may have a spinal nerve that actually is generated by multiple nerve roots coming together. But then when they all come together and exit through that intervertebral frame, and guess what? It now becomes a spinal nerve. Now, this is a very complicated concept that we introduced back when we talked about the upper extremities, the dermatomes. Now, derma is a Latin word that means skin. Tone means cut. So you can see here we've cut the body into different dermatomes, and these dermatomes correspond to the spinal level that provides this dermatome with its sensation. So you can see here, look across the anterior aspect of the thigh where we find L3. What that basically is saying, folks, is the L3 nerve root in the spine is responsible for sensation in this area, the anterior aspect of the thigh. That's the dermatome. Now, when we talk about myotomes, myotomes will be the muscular component. So the muscles that would correspond to the myotome for L3 would be the quadriceps. So let's say we have a client that has significant quadricep weakness and atrophy, as well as having significant pain in the L3 dermatome. What that would now indicate to a physician is, or a therapist or chiropractor or athletic trainer, that we may actually have some problems with the L3 nerve root in the spine that's producing both dermatome problems or dermatologic issues, as well as myotome issues. So both muscle and skin issues. Those two correlations together, those two correlating together now tells us there may be a neurologic problem. That's how we use myotomes and dermatomes. I know for some of you in the fitness industry, this may be something relatively new, and it's a new phenomenon. We need to do a better job with explaining this in our MEST program. When you actually come to the MEST on-site course, we actually give it even greater understanding and spend greater time on it. But this becomes vitally important. This is how, in many instances, physicians are able to determine if a client does have a neurologic problem, particularly a disc herniation, and where it's actually coming from. So this goes far beyond the idea of corrective exercise and the assessment. This is now the neurologic component that goes along with the assessment process. Here's our cervical vertebrae, and the key thing with the cervical vertebrae, folks, is these are like Corvettes. They're built low and fast and for mobility and speed. That's it. So you can see with these cervical vertebrae, they're smaller, they're sleeker, they have longer transverse processes. This allows us to have much greater mobility in the cervical spine, but we lose a significant amount of stability in the cervical spine. When we look at the vertebrae or vertebral comparison, you can see on the left here we have a lower level cervical vertebrae, and to the right here we have a lumbar vertebrae. You can see a significant difference between the two, but the neurologic arrangement is the same. We have the spinal cord and the exiting of those spinal nerve roots through the intervertebral foramen. Same thing here with the lumbar vertebrae. So they're very much similar in orientation and organization, but they do have a significant difference in the size of the vertebral body and the mobility that's offered in each area. You can see here we have also cervical degenerative joint disease. And with this cervical degenerative joint disease, you can see here we have a healthy cervical spine on the left. We have an arthritic cervical spine on the right. And we see the same thing in the lumbar region. So exact same thing. Okay. Okay, hold on one second. I got an email here. Looks like Rich Gafter is saying that he won't be able to in with the link that was provided earlier. Rich, give me just a second. There should have been a YouTube link, Rich, that also went out to you. Please check your email for that YouTube link. Okay, please check your email for that YouTube link. And give me just a second here, Rich. Let me see what I can do here for you. My apologies. Okay, Rich, I just sent over another link to you. Let's see if that works for you. All right, let's continue on. Now you can see here with the cervical nerve roots, you can see, or cervical nerve root compression, you can see the ligamentum flavum, how it compresses the spinal cord. You can also see here the bone spurs to the left side of the diagram, how those are compressing the cervical nerve roots. So, and you see the disc herniation occurring here. So this cervical nerve root compression, we can get it from bone spurs, a thickening ligamentum flavum, as well as a disc herniation, and we see the exact same thing occurring in the lumbar spine. Again, we have, with regard to cervical neurology, these nerve roots are all leaving the spine, and as they're leaving the spine, they're now how would I say, the best word is, they're like a conglomeration. They're actually conglomerating together to produce spinal nerves. So these nerve roots give rise to spinal nerves. So you may have a situation where you have multiple spinal nerve roots giving rise to a spinal nerve. And we see that a lot in neurology, particularly in the cervical spine, that we have to be mindful of. We have clients that have cervical injuries, cervical disc herniation, cervical surgery. Again, you can see the nerve root pathology here. You can see the disc herniation where it's compressing a nerve root. But the biggest thing we want you to see here is this brachial plexus as it's coming off the cervical spine. This brachial plexus is compromised at 3 points if there's a disc herniation, but also may be compromised by a first rib. And you can also see here the clavicle. Again, here are our dermatomes. They're broken down even more so here to correspond to the upper extremity. And now we look at the lumbar spine. We've seen this diagram before. We have a diagram to the left showing a lateral view of the lumbar spine, as well as a diagram here to the right showing a posterior view. Now, when we start talking about pathologies here, it's good to look at these pathologies with regard to having all of them together comparatively. So you can see we have a normal disc here at the top, or superiorly. Then we have a degenerative disc, where we're actually starting to see that disc narrow, a little bit of changes. Now we have a bulging disc next. It's actually bulging, and there's an area that's bulging into the area where the intervertebral foramen is located, which means a nerve root will be compressed there. Then we have a herniated disc, which means it's herniated all the way into the intervertebral foramen area. You can see we have a thinning disc, and this thinning disc is usually a result of a degenerative disc. Then we have a disc that has degeneration and osteophyte formations. Okay, we have 2 of those. So you could see here we have a varying range of pathologies with regard to arthritic changes, disc herniations, bulging disc, and we could see any of these and all of these in segments in the spine. We can have a disc herniation at one level, and then we can have an arthritic disc or disc degeneration at the next level. So you can see here you're going to have multiple situations that you'll encounter with these clients, and it becomes important that you understand what the doctors, therapists, and chiropractors are explaining with regard to the pathologies. Again, you can see here what's going on. This is in the cervical spine. So you got a stenosis going on here, and with that stenosis, it's a foraminal stenosis. That's going to now cause nerve root compression, but you can also see here we have a thickening of the ligamentum flavum. So we got all of this going on, and this is in the cervical spine, which means now this will produce central stenosis. Now we're looking in the lumbar region. You can see here the lumbar stenosis, and again, we can see the spinal cord is being compressed here as it's actually sitting in the vertebral foramen. Now here's our disc herniation. This is in the lumbar region. You can see our annulus is torn here. The nuclear material is herniated through, and it's compressing our lumbar nerve root here. With that lumbar nerve root compression, this is actually a phenomenon known as sciatica. Sciatica means nothing more than there is there's pain referred along the distribution of the sciatic nerve. It is a garbage term. It doesn't tell us specifically if it's a disc herniation or degenerative joint disease or a nerve root compression. It doesn't tell us. It just simply says there's pain along the distribution of the sciatic nerve. So when the client tells you they have sciatica, we need to get a little bit more information. We can't just simply go with that. We have to figure out why and what's going on. And if you've gone through these lessons, you'll understand I could have sciatica from a spondylolisthesis as well as sciatica from a disc herniation. I would position and manage each one exactly opposite, but they produce the same phenomena, the sciatica, the radiating pain down the sciatic nerve, or what we know as sciatica. Now, this diagram is very interesting because this diagram, I've shown this in the MEST program, this is from a gentleman by the name of Narkinson. This research was published back in the 1970s, and this completely revolutionized how we manage clients with back injuries, particularly disc herniations. And you can see here with this diagram, these diagrams are all based on the idea of how much compression there is at the L3 disc. So what Narkinson did was he figured out a way to measure this force at the L3 disc, and he found just simply lying down supine, there was about 25 pounds per square inch on the L3 disc. But when you rolled on your side, that went up to 3 times the amount, to 75 pounds per square inch. But what he used as his gold standard was standing, which is 100 pounds per square inch on that L3 disc. Look what happens when you bend forward. Just bending forward at the sink in the morning to brush your teeth, it goes up 50%. Look what happens when you hold a 3-pound object in your hand. It goes up to 220 pounds per square inch, which means if you've got a degenerative disc or disc herniation or degenerative joint disease, oh man, this is really causing a lot of compression in your spine. But here's what the real kicker was in the 1970s. Look what happens when you're sitting. It increases from 100 pounds per square inch to 140 pounds per square inch, a 40% increase. Look what happens when you sit and you slump. It goes up to 185 pounds. And look what happens when you sit, slump, and you hold 3-pound weights. 275 pounds per square inch. Moral of the story, folks, your clients that have any type of lumbar disorder, we don't want them sitting for long periods of time, nor do we want them doing a lot of forward bending. Okay, sitting forward bending, bad for lumbar issues. Now this shows us a spondylolisthesis, and now this is nothing more than we've got a vertebrae that's now slipped forward as a result of normally a fracture along the posterior aspect of the vertebral bodies. This fracture has now allowed this anterior translation of a vertebral body, but you can see here in this diagram that would compromise either the nerve root or possibly the spinal cord itself. So we can actually grade these spondylolistheses. And you can see here, this is even a better diagram. Normally we see these spondylolistheses occurring as a result of a violent movement into lumbar extension. That violent movement now causes the vertebrae, or the posterior aspects, to fracture, which now means this vertebrae is free to slip forward. Spondylo vertebrae, lolithesis means moving forward or sliding downhill. Now, what we need to do with these, and forgive me for going too far forward, we actually can grade these, and we showed you these in the grading in the MEST lumbar pathology lesson. So usually when we're looking at a grade 1 or 2 spondylolisthesis, those usually can be managed conservatively with exercise and bracing. When we're looking at a spondylolisthesis of grade 3, 4, or 5, those normally require some type of medical intervention. And if it's a 4 or 5, they usually require a spinal fusion be done. So please make sure, if you have clients that have spondylolisthesis, that you make sure they're going back periodically and having those spondylos reassessed to determine the amount of movement they have. That makes a huge difference in protecting the client from eventually having a damaged spinal cord or nerve roots. Now, in many instances, we have clients that undergo lumbar discectomies. And the discectomy is nothing more where they go in and actually remove a portion of the disc herniation. Now, I think we've got a better picture here. Nope. The discectomy is when we actually go in and remove a portion of the disc herniation. We also can have a laminectomy where we go in and remove a portion of the lamina itself. And remember we said earlier the lamina is that arch along the posterior aspect of the vertebrae. Now, we remove a lamina when we have a disc herniation because the herniation is compressing the nerve root against the lamina. By removing the lamina and then performing the disc discectomy, that actually now alleviates the problem for the most part. Now, sometimes we have clients that have had severe lumbar trauma. We may have to go in and do a fusion. And you can see here we have a fusion utilizing a Harrington's rod, a pedicle screw, as well as a fusion cage. What this does, it actually fuses the segment together with obviously the bolts, but obviously the fusion cage, what actually has bone chips in it, that now is actually going to, those bone chips are going to grow in, and they're going to actually fuse the area. So normally what we see is, usually after a disc herniation, with conservative care, it doesn't work. We normally will have a discectomy and a laminectomy. We normally will see spinal fusions as a result of severe trauma that results in severe instability in the spine, and or we may see these fusions done after a client has undergone a laminectomy, and then a few years later, when that laminectomy is no longer able to alleviate the client's pain, then they may come back and have a fusion done. So fusions are done usually in two situations: severe trauma, where the only option is to fuse the spine, and or client has had a laminectomy or more than one laminectomy, and the only option after the laminectomy is to actually now go in and fuse the spine to give it more stability. We also have a number of clients that have ankylosing spondylitis. Usually we see this in Eastern European males, or males of Eastern European descent. And literally what happens is the spinal segments fuse together. It starts in the lumbar spine, works its way up into the thoracic and cervical regions, and these vertebrae just simply fuse. They fuse together, and there's nothing we can do to stop it. Stretching, strengthening, mobilization will not stop it. This is a hereditary disease. It's passed on, obviously, genetically, and there's not a lot we can do about it. And I've seen patients that literally are bent over 70, 80, 90 degrees at the waist, and there's nothing we can do about it. It just is one of those things that happens. You can see we start with the normal posture, and then we move to a more ankylosed posture. I've even seen individuals with much greater ankylosing posture. And that takes us to scoliosis. Now, normally when we look at a scoliosis, we see an S-shaped curve. And this is daunting because you're like, oh my God, what am I going to do here? What do I start with? So best way to do this is to find the apex of the S and just cut it in half. Superior portion and inferior portion, which now breaks these into two C-shaped curves. And with the C-shaped curve, you're going to look at each C and you're going to manage the C curve below first, so the inferior one first. You're going to stretch the concave side and strengthen the convex side. Stretch the concave, strengthen the convex. Stretch the concave side. So the side where the C is closed, you stretch that side to stretch it out. The convex side, you want to strengthen that side so that we can actually get some strength back, so we can bring this spine back to alignment. That's the key with managing scoliosis. You've got to break the S apart into two C's, manage the lower C first, and the job is concave, stretch, convex, strengthen. Rinse and repeat 1,000,000 times. It just takes time to manage it. That also leads us to piriformis syndrome. And folks, we mentioned this in the MEST program. Piriformis syndrome does not occur anywhere near as often as we think. Okay? We will have some clients in true piriformis syndrome, we will have some clients that have that, where the sciatic nerve is piercing that piriformis, and that in turn, or activity is causing that piriformis to become inflamed. That piriformis becomes inflamed, it clamps down on the sciatic nerve, and there we go. But most times when we talk about piriformis syndrome, it's not really piriformis syndrome. It's really truly an SI joint problem. We go over this in great detail in the MEST on-site course, but also we go over it in the MEST lesson. So please remember, piriformis syndrome does not occur anywhere near as often as we think. It does occur. I don't dispute that. But in many instances, it's just an SI joint problem with a piriformis that actually has become aggravated. Again, you can see here the SI joint, and you also can see the piriformis. And you can see we have an SI joint problem. It could manifest itself and cause some problems with our piriformis. Now let's get into the screenings here for the lumbar spine. We've got 6 screening items we want to review. And with the screening, we have the straight leg raise test, which looks at disc involvement, the Laseg sign, which also looks at disc involvement, Hoover's test, not Hoover's test, but Hoover's test, it looks at sincere effort to see if the client actually is really giving us a true effort. The Thomas test, Ober test, and leg length discrepancy. Now, Thomas and Ober we'll look at a number of times. Okay, Ober test we'll look at periodically, and we really should add the Faber test here, but we're going to go over Faber test in the hip lesson. So the straight leg raise is just that. We just simply lift this leg, and we actually go over this in great detail in the MEST lessons on the assessment process in the spine. And what we're looking for here is to see if the client has a disc herniation or any type of nerve root compression that's actually going to traction that sciatic nerve. Laseg sign is nothing more than a more intense version of the straight leg raise. And now what we do is we just simply forcibly dorsiflex the ankle with that straight leg raise. If the client does have a space occupying lesion or nerve root compression or disc herniation, it's going to show up with this Laseg sign. Next one is Hover's test. We just simply put the palms underneath the client's heels. If the client is telling us he or she's having significant pain and they can't perform the activity or they can't lift the leg, if we put the palms underneath each one, what we should feel is if the client is giving us a sincere effort to lift the right leg, we should feel an increase in pressure as the heel of the left leg pushes down. If we don't feel that increase in pressure under the opposite heel that's being lifted, it tells us now the client may not be giving us a sincere effort. Now, please, as I mentioned in the MEST program, don't use the word malingering. For a Patrick test, we did include it. Forgive me, I didn't include it in our slide listing there. But the Faber-Patrick test is vitally important. This allows us to assess hip capsule mobility and flexibility. And I was talking to a good friend of mine, Carl Steele. He's probably one of the best manual therapists in the world. Carl is one of the adjunct faculty members at Michigan State University. And I was lucky enough to have Carl as my roommate when I was at Michigan State. He was a physical therapist going through osteopathic school at the time I met him. And he and I were talking the other night, and we both were saying that the Patrick or Faber test is a very important test because many instances you'll have clients come in, they'll report back pain, but that back pain is also continuous into the hip. And we're not really sure if it's hip pain or back pain, but what happens a lot of times is they'll be worked up for a lumbar problem. They'll go in and they'll have lumbar surgery because they do have arthritic changes there, but the problem actually is in their hip. Remember, the hip joint can refer into the lumbar spine, the lumbar spine can refer into the hip. So we've got to do this Patrick or Faber test. This allows us to assess the flexibility of the hip capsule as well as hip range of motion. And if we have a positive Faber test, that positive Faber test could be a result of lumbar issues, or it could be referring pain into the lumbar spine. So please clear the hip by doing this Faber or Patrick test. And you may find the client's problem is not their lumbar region. They may just have an early stage arthritic changes in the hip. And if we work on stretching out that hip, we may save them from having a total joint replacement. The Thomas test, this is vitally important in assessing flexibility of the IT band, the hip flexors or the rectus femoris, as well as the psoas, as well as the sartorius. Now, this is a vitally important test, but many clients that have acute back pain can't get into this position. But this does really give us a great idea about 4 muscle structures. And this goes far greater and much greater detail than anything we'll see in the corrective exercise arena. So this Thomas test is vitally important. We go over this in great detail in the MEST program. The Ober test, this looks at IT band flexibility and is a vitally important test. Now, between the two, Thomas allows us to look at the IT band as well as 3 other structures. If you do find that you have a problem with the IT band, go back and do Ober's test to confirm it. Now, Ober's test is a little bit more involved. It's a little bit more difficult to perform because of the length of the leg, but it is a test that you can use to confirm what you may find with the tight IT band with the Thomas test. And that leads us to our case studies, okay? Now, here's our first lumbar case study, or our first spinal case study. You got a 44-year-old male who's referred for spinal stability training. He has a history of an L3 disc herniation that occurred 2 years ago. He had a laminectomy 18 months ago, which means 6 months after the conservative treatment, they decided, hey, we're going to do this laminectomy. Prolonged sitting is not a problem for this gentleman. He does have centralized low back pain after golf and after lifting. It's centralized, no radiating pain. He's completed a program of physical therapy for pain management and strengthening. Please explain the pathology associated with the disc herniation. So explain to us what a disc herniation is. Explain what happens with the laminectomy. And if I'm not mistaken, this guy had a laminectomy 18 months ago. Explain what It goes on with the laminectomy. And please explain why prolonged sitting and spinal flexion are contraindicated for a disc herniation client. Okay. Case study number 2. Your client has sciatica. List all the conditions which sciatica is a symptom of. That might keep you busy for a long time. Also note with the conditions above, if the client with the condition above would prefer spinal flexion and or extension. In case study number 3, your new client has a history of 2 back surgeries, the result of a disc herniation 7 years ago. You're unsure of each surgical procedure. So if you would, please explain the exercise management for a disc herniation, a spondylolisthesis, central stenosis, lateral stenosis, and degenerative joint disease. Okay, now we're going to ask you to critically think a little bit. Submit your answers to the case studies via email, with the regular case studies that you're going to do for this section. And we're now going to start talking about the exam review. Okay, so these are some of the items from the exam review guide. Okay, number 80. Describe the lumbar vertebrae and the motions available in the lumbar region. Lumbar vertebrae are very short and stocky. Actually, it's kind of like a block, for lack of a better phrase. And the primary motion we'll see in the lumbar spine is flexion and extension. There is some rotation and some side bending, very little rotation. Rotation mostly occurs in the thoracic regions, primarily flexion and extension, and then side bending. You'll find that in lesson 17. Number 81, describe the nucleus fibrosus. The nucleus fibrosus is that outer shell of the disc. It's made up of anywhere from 13 to 20 rings, depending upon who you talk to or which anatomist you're reading. And each layer of the annulus, the fibers run in a different direction to actually reinforce it and make it stronger, like a steel belted tire. You'll find that in lesson 17. Number 82, describe the nucleus pulposus. This is found in lesson 17. The nucleus pulposus is that gel-like substance that's inside or protected by the annulus. And remember that nucleus pulposus loses water over time. So it goes from being more gelatinous-like to being more of a kind of a gelatinous structure that doesn't have much water content. You'll find that in lesson 17. Number 83, describe the intervertebral end plate. The end plates are found both superior and inferior, so they're found on both the superior portion of the end plate as well as the inferior portion. And these end plates allow nutrients to pass through into the disc directly. Now, they're made of fibrocartilage, which means they're very often damaged. 17, describe the spinal motion segment. We looked at that earlier. The vertebrae above, the vertebrae below, the disc in between, and all the posterior segments. This is the basic essence of motion in the spine. Number 85, describe the intervertebral foramen and the nerve structure passing through it. Well, the intervertebral foramen is that opening through which the spinal nerve root passes. Lesson 17. Number 86, describe the vertebral foramen and the nerve structure found within. Now, the vertebral foramen is where we find the spinal cord. So the foramen actually is that circular open area within each vertebrae. It's just posterior to the vertebral body, and the spinal cord sits in there. Okay, so that actually is the spinal canal. The spinal canal is formed by a series of intervertebral foramen. Number 87, please describe the following spinal conditions: degenerative joint disease, disc herniation, facet joint syndrome, and spondylolisthesis. You'll find these in lesson 17. I'll let you actually go in, write the narratives for each one of these. But degenerative joint disease, good old arthritis. Disc herniation, the annulus has torn and the nucleus is actually herniated through. Facet joint syndrome, arthritic changes in the facet joint, either the superior articular process or the inferior articular process. And the spondylolisthesis is when we actually have a fracture of those posterior aspects of the vertebral segment, and now the vertebral body can anteriorly translate. That's from lesson 17. Number 88, describe the components and the primary function of the facet joint. Okay, the facet joint is primarily designed to stop spinal extension and control, to some degree, side bending and also rotation. You'll find that in lesson 17. And remember, that facet joint is covered with hyaline cartilage. Number 89, describe the differences in the vertebral body, the transverse and spinous processes found in the lumbar and thoracic spines. Well, the vertebral bodies are different in that the lumbar vertebral body is nice and thick and designed for weight bearing. The thoracic is rather thin, sometimes rather long. The transverse processes in the lumbar vertebrae as well as the spinous processes are very thick and very stubby, whereas in the thoracic region they're relatively long and slender, and the thoracic region is designed to give us spinal rotation. In the lumbar region, these are designed primarily, the vertebrae are designed primarily for weight bearing, inflection, extension, and rotation. Lesson 17. Number 90, describe the anterior and posterior longitudinal ligaments and the ligamentum, flavum, and their importance to spinal function. Well, the anterior runs along the anterior aspect, the posterior runs along the posterior aspect, but sitting in the spinal canal itself, the vertebral framing, is that ligamentum flavum. And it really doesn't do anything except get in there. And when it becomes inflamed, it becomes thickened. That causes spinal stenosis. The anterior longitudinal ligament prevents too much extension. The posterior longitudinal ligament really prevents too much flexion. Doesn't do that too well. But one of the reasons we very seldom see anterior disc herniations is because of that anterior longitudinal ligament. This is lesson 17. Number 21, describe why the quadratus lumborum is the workhorse of the spine. It's the workhorse because literally it does all the work. Once you get past 70 degrees of spinal flexion, that quadratus is the thing that's going to bring you back up from that position, and it's a thick muscle with 3 layers. And those 3 layers really work hard to stabilize the spine. They help with rotation, side bending, and even bringing you back up from flexion. So they are helpers in extension. Number 92, describe the importance of the multifidi as intersegmental spinal stabilizers. This is from lesson 17. Now, remember we said with the multifidi, they have 2 heads, a short head and a long head. They start out in the spinous process, go down and attach to the transverse process, 1 level below, short head, 2 levels below for the long head. They do this on both sides of the spine, which means we have this intricate network of short muscle structures that contract and pull the spinal segments together. That's intersegmental stability. Okay, that's lesson 17. This is vitally, vitally important. Now, folks, hopefully you picked up, these are all items from the MEST exam review guide. I'm explaining them to you just like you should explain them to your friend, lover, and a colleague. Now, of course, I've been doing this longer. I've been around this information longer, but we want you to get to the point where you're literally explaining this to someone else. Number 93, describe the importance of the lumbar protective mechanism and how it protects the spine. That protective mechanism is all of these layered muscles together, all working to absorb force from different vectors, absorb that force with the muscles and dissipate it so it doesn't damage the spinal vertebrae, nor does it damage any soft tissue structures, ligaments, cartilage, disc components in that lumbar region. So these muscles have to not only be strong, but they have to be able to contract rapidly. They have to be able to right positioning, as in I start to lose my balance or I start to get off balance. They have to now correct that and absorb that force so it doesn't go into that lumbar vertebrae. Number 94, describe the common lumbar pathologies and symptoms associated with, I'm sorry, this slide is so far off. Degenerative joint disease, that's nothing but good old osteoarthritis. We're starting to see changes at the end plate as well as the facet joint. Disc herniation, this is nothing more than the annular fibers have torn and the nucleus is herniated through. And facet joint syndrome is nothing more than damage or changes to the intervertebral, to the articular cartilage that covers the superior articular process or the inferior articular process or the facet joint. Number 95, describe the function and importance of dermatomes and myotones. We talked about this a little bit earlier. Dermatomes are the skin areas or the cutaneous areas that are innervated by a spinal nerve root. The myotomes are the muscle structures innervated by a spinal nerve root. Now remember, multiple nerve roots can come together and give rise to a nerve that in turn innervates a particular area. So these myotomes and dermatomes are important in that they help us understand the neurology of the spine and how that works. Number 96, list the MET criteria for degenerative joint disease. Now, as I've done in previous sessions, the MET criteria, the goals, the exercises, I'm going to let you go into the lessons and actually list yourself, because we could be here forever listing all the criteria. Remember, with the criteria, we're only expecting you to know maybe 2 or 3 of the criteria. or the goals or the important points or MET management guidelines. We're not expecting you to know those verbatim, but you need to be familiar with them. Number 96 lists the 3 key components in MET management of degenerative joint disease. Again, there may be a number listed there, but just have a basic understanding of the basic 3. Lesson 18. Number 98 lists the 3 key exercises in MET management of degenerative joint disease. There may be a number listed there. Just know 2 or 3 of those. Number 99 lists the muscles associated with L3, L4, and L5 myotomes. Now, folks, I don't even know this one right off the top of my head, but are listed in the MEST program, or if not, we're asking you to go out and look those up. Now, I know L3 is going to be the quadriceps. Folks, I'm an old man. I don't remember all of these right off the top of my head, but we're going to ask you to start to remember these and also remember the dermatomes associated. Number 100, explain the terms radiating pain and referred pain. Radiating pain means the pain is actually radiating down, say, the sciatic nerve. I've got a disc herniation and it's causing pain radiating down that leg. So it's right along the distribution of the sciatic nerve. Referred pain is a little bit different though. Let's say I have a disc herniation at L3. I don't have any pain radiating down the sciatic nerve, but I have pain, and I have significant pain in the L3 dermatome, which is the anterior aspect of the thigh, and I can't figure out why my thigh hurts. It's not coming from your thigh, it's coming from the L3 disc herniation, and that's referred pain. Number 101, describe the cervical oswestry scale and list its indications. Now, this is listed in reviewed in lesson 43. The cervical oswestry, and there's a lumbar oswestry too. This is a means, and it's somewhat subjective, a means of getting an idea of the client's functional capabilities in the cervical region. The lumbar oswestry looks at functional capabilities in the lumbar region, and these are reviewed in lesson number 43. Number 102, identify the 3 locations in the lumbar spine where degenerative disc disease usually begins. That would be the disc herniation or the disc, the facet joint, or the intervertebral end plate. That's lessons 17 and 18. Number 103, explain Laseg sign and when it's used in the MET assessment. If you think a client has a disc herniation, but you don't have the diagnosis, and they're complaining of pain with sitting for long periods of time and radiating pain, and you've done the straight leg raise and it's not, client doesn't quite have any pain, then add a little bit, just a very, very low intensity Laseg sign. If that causes it, then you're going to refer that client to their doctor and tell the doctor that, hey, there might be something going on with the disc. Don't diagnose, nor tell the client, give the client a diagnosis. Just want to get them, refer them out as necessary. Number 104, explain the degenerative cascade. Now, this degenerative cascade is vitally important. The cascade, lesson 18, means nothing more than we have an area that's arterial, a facet joint, an implant disc. One of those areas now causes arterial changes, and those arterial changes lead to generation of these other areas. So over time, we find that this vertebral unit is it properly now abnormal load-ups, abnormal change those areas, and that in turn cause arterial change down the cascade. This concept, the degenerative cascade, show. It was originally identified by a Canadian called Lawson, an excellent clinician. He was from the University of, I believe, Saskatchewan, if I'm not mistaken. Excellent clinician, and this is written about in a number of textbooks, and this has now been accepted as a degenerative disease occurs. The key thing that they noted in all this research was this could be arrested or slowed down with spinal stabilization exercises. Lesson 18. Number 105, explain spinal stenosis and the differences in lateral and central stenosis. Now, stenosis means nothing more, spinal stenosis means nothing more than the narrowing of the frame, intervertebral or vertebral. Central stenosis means a narrowing of the vertebral foramen, which means the spinal cord is being compressed. That will normally produce symptoms in both legs. Lateral stenosis, though, means the intervertebral foramen is being stenosed. It's narrowing as a result of facet joint damage, a disc herniation, or end plate damage, and that will produce pain radiating down a leg. Lesson 18. Number 105, describe the nerve root and how it gives rise to a spinal nerve. Now, a nerve root is the thing that exits the spinal cord. That nerve root, as it continues on and exits out through the intervertebral frame, it becomes a spinal nerve root. I'm sorry, it becomes a spinal nerve. Excuse me. It's a nerve root when it is a little sprout leaving the spinal cord. When it exits the intervertebral foramen, it's now a spinal nerve. My apologies. Lesson 17A. Number 107, explain multifidi changes with chronic pain, disc herniation, and back surgery. The changes we see are the multifidi will atrophy, the number of mitochondria in it will decrease, which means it has less energy, and we also see its contraction time goes from rather rapid to actually becoming a little slower, so it becomes more of a slow twitch fiber, which means now it's not there to contract rapidly to stabilize an area. Number 108, list the criteria the conditions that may cause sciatica: disc herniation, fracture, piriformis syndrome, infection, spondylolisthesis, any number of things. Lesson 18A. Number 109, explain the motion occurring in the facet joint, the intervertebral foramen, and the spinal disc during spinal flexion and extension. This is a challenging one. So if I go into extension, the facet joint closes, the intervertebral foramen narrows, and the nucleus moves forward, or the spinal disc moves forward. If I go into flexion, the facet joint opens, the intervertebral foramen opens, and the disc moves posteriorly. Lesson 18. That, folks, you do need to know verbatim. Number 110, explain Narcomson's study with disc compression in sitting and standing. Basically, all he said was the worst thing to do for a person that has discogenic problems, or the problem with the disc, is to have them sitting or standing. Have them sitting for long periods of time. Standing actually is better than sitting. Sitting, we see an increase of at least 40%, and sitting and leaning forward, upwards of 80% difference. Whereas standing, we actually find standing is better for the client with any type of disc problem. That's why when we send people back to work with disc injuries, we want them to be able to get up and move around. We don't want them stuck in a desk job. Number 111, list the MET criteria for the lumbar disc herniation, degenerative joint disease, and spondylolisthesis. Lesson 18, I'll let you list those. Number 112, describe the importance of lower extremity motor function when testing, lower extremity motor function testing when assessing lumbar conditions. If the client is showing a pattern of weakness with certain muscle structures that are related to the same myotome, along with dermatome increased pain or decreased sensation, that's telling us there's a disc problem going on, a disc herniation or nerve root compression going on. That client, if we see that motor function has gotten to the point where they now are dysfunctional, that now means we've gone beyond the point of conservative care. We may now need to have surgical intervention. Number 113, describe the importance of the positive straight leg raise test. This indicates the client may have a space occupying lesion or a disc herniation in the spine that's compressing the nerve root. That client needs to be referred to their doctor, or we need to put them on a very strict program to avoid excessive spinal flexion. Number 114, list the MET criteria for the lumbar disc herniation client. I'll let you list those. Lesson 18. Number 115, describe the most common cause of spondylolisthesis. It's usually a violent motion or violent movement into spinal extension. Number 116, describe the grading process used to assess the spondylolisthesis. Real simple. Have the client stand, we shoot an x-ray. Now have the client move into extension, shoot another x-ray, overlay the extension x-ray on the standing x-ray, and just simply measure the distance. And that measurement is anywhere from a grade 1 to a grade 5 or 6, depending on which scale you're using. And that measurement, how much motion that's occurring there, will determine what the physician and or surgeon will do as far as management of the spondylolisthesis. That's from lesson 18. Number 117, list the MET criteria for spondylolisthesis. I'll let you list those. Number 118, describe the lumbar oswestry scale and list its indications. The lumbar oswestry is nothing more than the lumbar version of the cervical oswestry. It's a battery of questions we'll ask the client with regard to their lumbar capacity. The client will answer based on their best recollection, and we just simply total the point values up from these areas. I believe there are 12 areas that we look at. and with the number of responses, usually 5 to 6 responses the client can provide. Each one has a point value. We add those up, and that now gives us a snapshot of the client's lumbar capability. Now, it is subjective, but as long as we're comparing apples to apples, the client's apples to the client's apples, that means we do it on day 1, we do it on day 30, and we're comparing it together. This now will allow us to get a better idea of the client's lumbar functional capabilities. Number 119, explains the spinal extension range of motion limit with spondylolithisis. Client has spondylolithisis. We don't want them extending past 10 degrees of lumbar extension. I normally maintain we don't want the client going past neutral, because at neutral, most people are going to go into a little bit of extension. When we go past 10 degrees, we're now really compromising the vertebral segments and may cause even greater spondylolithisis. Number 120, explain the differences between the straight leg raise test and Laseg sign. Straight leg raise is just that. Laseg sign is a straight leg raise with a little bit of provocation by dorsiflexing the ankle. Number 121, describe the Hover test and its indications during the spinal assessment. Hover's test gives us an idea if the client is giving us a true, sincere effort. If we don't think they're giving us a sincere effort, then we may need to move the client on to other services. Number 121, describe the contraindications for the Thomas test during the spinal assessment. If the client has had surgical intervention in the lumbar spine, or they have a disc herniation, or they have an acute pain, don't do the Thomas test. And lastly, number 123, the lumbar case studies, which we went over right at the end of our slide presentation, describe the related anatomy, pathology, precautions, criteria, goals, and 3 key MET management concepts. 3 key MET exercises in a 60-minute program design for weeks 1 through 8 from MEST lesson 21. So you got enough here to keep you out of trouble for a long time. So let me escape out of this. We'll go back to our lesson here, and we're going to call it a night. So we're going to stop screen sharing. Hopefully we didn't lose too many people. Hopefully we got a good recording on this. And folks, again, thank you for joining us. Thank you for your patience. I know this has been kind of a difficult time because of the changes that are going on with Google Hangouts. It's beyond our control. If we find that we're not able to do anything better with this, next week we'll probably switch over and start using there's another program, GoToMeeting or GoToWebinar. So we'll probably start using that if we don't see this clear up. So again, my apologies, but thank you for being patient and being along with us. The recording for this will go up first thing this evening, or as soon as we get the download from YouTube. That way you won't miss out on anything. And please, again, accept my apologies. And if you have questions, email me at drmike@postrehab.com. Thanks again, folks. Have a good evening. Bye-bye.